Welcome to the deep dive. Today, we're tackling appendicitis.
Yeah, it's one of those conditions. Well, a lot of people know someone who's had it or might even experience it themselves.
Exactly. Seems simple on the surface, maybe, but there's actually quite a bit of key info you need to get a handle on, especially for revision.
Absolutely. So our mission today is really to pull out the crucial high-yield stuff about appendicitis from the notes.
Right. We want to give you a clear path through it all.
We'll cover the basics, what it is, what causes it, who's at risk.
How it actually develops, the pathophysiology, then what else it could be, the differentials.
Yeah, and how common it is, the symptoms, how we check for it.
Investigations, right. And then management, prognosis, and complications too.
And we've got some memory tips sprinkled in to hopefully make things stick a bit better.
Great. So no need to feel overwhelmed. We'll break it down. Let's dive in. What exactly is appendicitis?
Okay, so fundamentally, it's inflammation of the vermiform appendix.
That little pouch thing attached to the large intestine?
That's the one. And the inflammation usually starts because the lumen, the sort of channel inside the appendix, gets blocked.
Blocked? By what? We'll get to that, I guess, but what happens when it's blocked?
Well, once it's obstructed, the normal bacteria that live in your gut can kind of take over. They invade the appendix wall.
Leading to the inflammation and infection.
Exactly. And if that process isn't stopped, it can get worse. The tissue can lose its blood supply, that's ischemia.
Okay.
Then it can perforate, basically develop a hole. You might get an abscess forming, which is a collection of pus.
And if it actually bursts?
That's when you risk peritonitis, a really serious infection of the lining of the whole abdomen.
Wow. Okay, so it escalates quickly. And it's a big reason for acute abdominal pain, often needing emergency surgery.
Definitely a key cause of the acute abdomen.
So let's talk about the initial blockage. What typically causes it? What's the etiology?
The most common culprit is actually hardened fecal matter. A small, hard piece of stool, basically. We call it a faecoliths sometimes.
Right, like a little stone getting stuck. Makes sense. That's the most common.
Yeah. Another fairly common cause is swollen lymphoid tissue.
Like lymph nodes in the appendix.
Kind of. There's lymphoid tissue in the appendix wall, and just like your glands swell up when you have a throat infection, this tissue can swell and block the lumen.
Interesting. Anything else?
Much more rarely, maybe a foreign body, like perhaps a seed or something very small getting lodged in there.
Yeah.
But that's uncommon.
Okay. So fecal matter or swollen tissue are the main things. Once that blockage happens, what's the mechanism?
So the blockage traps mucus and fluid inside the appendix. This makes the pressure inside rise quite quickly.
Right, like blocking a pipe.
Exactly. And this increased pressure squeezes the blood vessels in the appendix wall.
Reducing blood flow.
Yes, which leads to that ischemia we mentioned. The tissue starts getting damaged because it's starved of oxygen. And at the same time, the trapped bacteria just multiply like crazy in that environment.
So it's a vicious cycle. Blockage, pressure, poor blood flow, bacterial overgrowth, more inflammation.
Precisely. That's the sequence.
Okay. Now, who is most likely to get appendicitis? What are the risk factors?
Age is a big one. It's most common in children and young adults.
What sort of age range are we talking?
Typically between 10 and 30 years old. The absolute peak incidence is probably in the second decade, so teens and early 20s, like 10 to 20.
And gender?
There's a slight tendency for it to be more common in males. Just slightly.
Okay. Any other factors?
Family history seems to play a part. If you have close relatives who've had appendicitis, your risk might be a bit higher. Suggests maybe a genetic link.
Interesting. What about other medical conditions?
Yeah, certain underlying conditions can increase the risk. Things like Crohn's disease, for example.
Okay.
And also conditions that might lead to more fecal matter buildup or that lymphoid hyperplasia, the swollen tissue we talked about. So things like cystic fibrosis or even inflammatory bowel disease could potentially be factors.
Right. So key risks: young age, male, family history, and some specific conditions. Let's get into the pathophysiology again, maybe step by step.
Sure. So step one is the obstruction of that lumen, whatever the cause, faecolith, lymphoid tissue.
Got it. Blockage first.
Step two, because stuff can't get out, the appendix distends, it swells up, and the pressure inside the intraluminal pressure increases.
Okay.
Step three, that high pressure compresses the blood vessels. Blood flow is compromised, leading to ischemia of the appendix wall, and inflammation starts.
The wall starts to suffer.
Step four, with the blockage persisting and the wall weakening, those gut bacteria invade the tissue. You get infection, more bacterial overgrowth, more inflammation.
It really ramps up then.
Yeah. And step five, if it's not treated, the inflammation and ischemia lead to tissue death necrosis. The wall weakens further and can eventually rupture or perforate.
And that's when the infected contents spill out.
Exactly. Into the peritoneal cavity, potentially causing peritonitis, which, as we said, is a serious, potentially life-threatening situation.
That step-by-step really clarifies the progression and the danger.
Okay, so someone comes in with abdominal pain. Appendicitis is on the list, but what else could it be? The differentials are pretty broad, right?
Oh, definitely. Abdominal pain is tricky. Within the GI system alone, you've got to think about bowel obstruction, maybe into intussusception, especially in kids.
Where the bowel telescopes into itself.
Yeah. Then hernia,
Mm-hmm.
cholecystitis, gallbladder inflammation, a perforated ulcer, diverticulitis.
Especially in older patients for diverticulitis.
Right. Mesenteric adenitis, those swollen lymph nodes in the belly, often after a virus, common in kids. Crohn's disease again, pancreatitis, simple gastroenteritis, even colon cancer, though less likely in the typical appendicitis age group.
That's just the gut. What about other systems?
Well, urology, you have to consider testicular torsion in males, kidney stones, urinary tract infections.
Okay.
And in women, the gynecological causes are really important differentials. Ectopic pregnancy is a big one.
Must rule that out.
Absolutely. Also, ovarian torsion or ruptured ovarian cyst, pelvic inflammatory disease. So many possibilities. Any others?
Yeah, a few sort of other things. Diabetic ketoacidosis can sometimes present with abdominal pain. Even pneumonia, particularly lower lobe, can cause referred pain. Effects from certain immune therapies, and a psoas abscess.
An infection in that hip flexor muscle?
Yeah, it sits right behind the area, so inflammation there can mimic appendicitis pain. It's quite a list to work through.
It really highlights why getting the diagnosis right is key. Okay, let's zoom out again. Epidemiology, how common is this really?
It's one of the most common reasons for emergency abdominal surgery worldwide.
Right.
We mentioned the peak age, 10 to 30, slight male predominance. In the UK, the incidence is roughly 70 to 80 cases per 100,000 people each year.
Okay.
Globally, the number's a bit higher, maybe around 223 per 100,000. It's a very common cause of that acute abdomen presentation.
And the notes said something like 10% of people get it in their lifetime?
Yeah, approximately. Lifetime risk is around that mark.
Yeah.
Maybe slightly less, maybe 7-9% depending on the study, but it's significant. It affects a lot of people, mostly adolescents and young adults.
And that point about normal appendices being removed.
Ah, yes, the negative appendectomy rate. It's estimated that in about 10-20% of surgeries done for suspected appendicitis, the appendix turns out to be normal on pathology.
Wow.
It reflects the diagnostic challenge. Surgeons often have to weigh the risk of operating unnecessarily against the risk of missing appendicitis and having it perforate.
A tough balancing act. Okay, so what are the classic signs and symptoms, the clinical features we look for?
The absolute hallmark symptom is abdominal pain, and it typically has this characteristic progression.
Tell us about that.
Usually starts quite gradually, often described as being around the umbilicus, the belly button area, kind of vague initially.
Okay, central pain first.
Then, over several hours, maybe 6 to 12 hours, the pain tends to migrate, to shift downwards and to the right, settling in the right iliac fossa, or the right lower quadrant.
That migration is key then.
Very characteristic, yes. And the pain is typically worsened by movement. Things like coughing, walking, even going over bumps in the car can aggravate it.
Right. What else accompanies the pain usually?
Loss of appetite, anorexia is very common, nausea, and sometimes vomiting, although the vomiting isn't usually severe or persistent.
Okay.
A low-grade fever, mild pyrexia is also pretty typical. And of course, tenderness when you physically examine the right lower abdomen.
But it's not always that straightforward, is it? What about atypical presentations?
No, definitely not always textbook. Some people might present with symptoms like indigestion or feeling gassy, maybe bowel irregularity, constipation, or sometimes diarrhea. Just a general feeling of being unwell, malaise. These atypical features can make diagnosis harder.
Good to keep in mind. And those physical exam signs with the specific names.
Ah, yes, the classic signs. Tenderness, specifically at McBurney's point, that's about 2/3 of the way from the umbilicus to the bony point on the front of the hip on the right side.
Got it.
Then there's Rovsing's sign pressing in the left lower quadrant, causes pain in the right lower quadrant.
Okay, why does that happen?
It's thought to be due to stretching the peritoneum over the inflamed appendix when you push on the other side.
Makes sense. What about the others?
The psoas sign pain, when you extend the patient's right hip, especially if they're lying on their left side, this suggests the inflammation is irritating the psoas muscle behind it.
Right.
And the obturator sign pain, when you flex the patient's right hip and knee and then internally rotate the hip. This suggests irritation of the obturator internus muscle.
Okay. And generally, you'd find localized tenderness, maybe some guarding.
Yes, involuntary tensing of the abdominal muscles over the inflamed area, that's guarding. And rebound tenderness pain that's worse when you quickly release pressure than when you press down. That suggests peritoneal irritation.
And the scoring systems you mentioned earlier, Alvarado, AR.
Yeah, these are tools used often in A&E to try and stratify risk. The Alvarado score, for example, assigns points for different features: migratory pain, anorexia, nausea, tenderness in the right lower quadrant, rebound tenderness, fever, elevated white cells, and a shift to the left in the white cell count.
Okay.
A score of, say, 0.3 or 0.4 makes appendicitis less likely. A score of 7 or more makes it quite likely, and maybe 9 or 10 strongly suggest you need to think about surgery. Intermediate scores often prompt further investigation, like imaging. The AR score is another similar tool.
So they help guide the next steps. Speaking of which, investigations, how do we confirm the diagnosis?
It's usually a combination, like we said. History, examination, and then investigations. Blood tests are standard.
What do you look for in the bloods?
A full blood counts, or CBC. You often see a mild leukocytosis, a raised white blood cell count.
Right.
But importantly, a normal white count doesn't rule it out. You might also see a predominance of neutrophils, which are a type of white blood cell involved in bacterial infection. That's seen in maybe 80–90% of cases. Quick memory tip. Think N for neutrophils and N for near the appendix where the pain is.
Nice tip. What about inflammatory markers?
Things like C-reactive protein, CRP. It's often raised, but it can be normal early on or might not be very high. It's not perfectly sensitive or specific on its own.
So bloods give clues but aren't definitive. Urine tests.
Urine analysis is important, mainly to rule out other things, especially a pregnancy test in women of childbearing age.
Crucial.
And checking for signs of a urinary tract infection, like nitrites or significant white cells. You might see a few white cells in the urine with appendicitis due to nearby inflammation, but usually no nitrites.
Okay. And then imaging. Ultrasound versus CT.
Imaging is often key, especially if the diagnosis isn't clinically obvious. Ultrasound is generally the first choice for children, young people, and pregnant patients.
Why them specifically?
Less radiation compared to CT, which is a concern, especially in kids and during pregnancy. Ultrasound is also pretty good at looking for alternative diagnoses, particularly gynecological problems in women presenting with right iliac fossa pain. Finding free fluid on ultrasound can also suggest perforation.
But for other adults?
For most non-pregnant adults, CT scan is generally preferred. It has higher diagnostic accuracy. It's more sensitive and specific for appendicitis than ultrasound in this group.
But the radiation?
Yes, that's the downside. There's growing interest in using low-dose CT protocols to try and minimize radiation exposure while maintaining accuracy. MRI is another option, mainly used in pregnant women if the ultrasound isn't conclusive.
And plain x-rays?
Usually not very helpful for diagnosing appendicitis itself. You might occasionally see a faecolith, but it's not reliable. Memory tip. Think US for under 30s and pregnant patients. CT for the sort of classic adult presentation where you need high accuracy.
Good way to remember. The notes also mention clinical diagnosis being possible sometimes.
Yeah, in some cases, maybe a thin male patient with absolutely classic symptoms and signs. A surgeon might feel confident enough to proceed based on clinical assessment alone. But this is becoming less common, and it's unreliable, especially in atypical groups like pregnant women, older adults, or very young children, where symptoms can be different.
And diagnostic laparoscopy.
That's sometimes used if the diagnosis is still uncertain after other tests. It involves putting a camera into the abdomen surgically to directly visualize the appendix. If it's inflamed, they can proceed to remove it in the same operation.
Right. Confirms and treats, potentially. So once it is diagnosed, what's the standard management?
The standard treatment is surgical removal of the appendix, an appendectomy, or often called an appendicectomy.
Open or keyhole.
It can be done either way, open surgery through a larger incision, or laparoscopically using small incisions and a camera. Laparoscopic appendectomy is generally the preferred approach these days.
Why is that?
Usually leads to a shorter hospital stay, quicker recovery, less postoperative pain, and better cosmetic results. It's suitable for both uncomplicated and complicated appendicitis, like perforated cases.
And antibiotics.
Yes. Prophylactic intravenous antibiotics are given before surgery to help reduce the risk of wound infections and intra-abdominal abscesses later on.
What if it's already perforated when diagnosed?
Management depends a bit on the situation. If it's a contained perforation, maybe with an abscess and the patient is stable, sometimes the initial approach is IV antibiotics, and maybe draining the abscess percutaneously through the skin with a needle, with an appendectomy planned for later delayed appendectomy.
Okay.
But if the patient is unstable or there's widespread peritonitis from the perforation, then it's usually immediate surgery to remove the appendix and wash out the abdomen, along with strong IV antibiotics.
Makes sense. Now, what about that idea of treating just with antibiotics, no surgery?
Yeah, that's been looked at quite a bit, sometimes called conservative management. It's controversial.
Ah.
Well, some studies show it can work for uncomplicated appendicitis, but the main issue is the recurrence rate. A significant number of patients treated with antibiotics alone will end up developing appendicitis again later.
How high is that recurrence?
It varies, but some studies suggest it could be up to around 39% within 5 years. So surgery remains the definitive treatment to prevent recurrence. This antibiotic-first approach did gain some traction during the COVID-19 pandemic when there were concerns about surgical capacity and exposure.
So, an option in specific circumstances maybe, but surgery is still the gold standard?
Generally, yes. Observation is also mentioned sometimes if the diagnosis is really uncertain. A period of active observation in hospital with reassessment might be chosen before committing to surgery or other treatments.
And supportive care is always important.
Absolutely. Intravenous fluids to keep hydrated and good pain relief analgesia are essential parts of the management for anyone admitted with suspected appendicitis.
Okay, so key points. Admit suspected cases. Surgery is primary treatment. Antibiotics are crucial pre-op, and for complications, conservative management is debated. What about the outcome? Prognosis.
If it's caught and treated promptly, the prognosis is generally excellent.
Appendectomy is pretty safe.
Yes, for non-perforated appendicitis, the mortality rate is very low, something like 0.8 per 1,000 operations.
That's very low.
Even if it has perforated, while the risk is higher, the mortality is still relatively low overall, maybe around 5.1 per 1,000. The big variable is age, unfortunately.
How does age impact it?
In elderly patients, say over 70, the mortality rate can be significantly higher, sometimes quoted as over 20%.
Wow, why such a big difference?
Often a combination of factors. Symptoms can be more subtle or atypical in older adults, leading to delays in diagnosis and treatment. The disease might progress more rapidly, and they often have other underlying health problems, comorbidities, that make surgery riskier and recovery more difficult.
A really important consideration. Finally, if appendicitis isn't treated, what are the potential complications we need to worry about?
We've touched on the main ones. Appendix rupture or perforation is the big one. Spread of infection throughout the abdomen, peritonitis. Another common issue is the formation of an appendix mass, which is where the body tries to wall off the infection, forming a lump of inflamed tissue and potentially pus. Or a distinct abscess can form.
Okay.
Sometimes the inflammation can cause the bowels nearby to temporarily stop working properly. That's called a paralytic ileus.
Any other rare things?
Less commonly, you could get intestinal obstruction from adhesions later on, or sepsis. That's a severe body-wide infection that can be life-threatening.
And these are all complications of untreated appendicitis.
Yes, primarily. It really underscores why timely diagnosis and intervention are so important.
Absolutely. So just to quickly recap this deep dive, appendicitis is inflammation, usually from blockage, most often faecolith or lymphoid tissue. Risk factors include being young, male, family history. It progresses from blockage to pressure, ischemia, infection, and potential rupture.
Right. Lots of differentials to consider, especially GI, urological, and gynecological causes. It's a very common surgical emergency, peak age 10-30.
Classic feature is that migrating pain from umbilicus to right iliac fossa, plus anorexia, nausea, fever, local tenderness, but atypical presentations happen.
Investigations involve bloods, WCC, neutrophils, CRP, urine tests, and crucially imaging, usually ultrasound for kids, pregnant women, CT for other adults. Scoring systems can help stratify risk.
Management is typically laparoscopic appendectomy with pre-op antibiotics. Perforation needs urgent attention. Antibiotic-only treatment is an option sometimes, but has higher recurrence.
Prognosis is excellent if treated promptly, though worse in the elderly. Complications of delay include rupture, peritonitis, abscess, and potentially sepsis.
It seems simple, but definitely isn't. Understanding all those steps and possibilities is crucial.
It really is. It highlights how even common conditions have complexities that matter hugely in clinical practice, especially when you're revising for something like the MSRA.
Definitely. And speaking of revision, if you want more resources to help you prepare for the MSRA, do check out passmsra.com.
And also freemsra.com for more helpful materials.
Great resources. Well, that wraps up our deep dive on appendicitis. Thanks for joining us.